Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. All right, welcome everyone to the June 2022 Pre-Hospital Care Research Forum Education Research Journal Club. A big thank you to Limmer Education for providing us support to the PCRF Journal Club, supporting the science of EMS and EMS education. My name is Megan Corey. I'm here with Katie O'Connor, and Alex Tremblay is out there somewhere stuck in the matrix. We're trying to pull him out of cyberspace as a panelist. And also we're going to have Dr. Kim McKenna is going to join us for a bit during a break. She's teaching right now. And of course, Dr. Bill Toon will be joining us soon as well. Dave Page is traveling at the moment. So today we're going to be looking at an interesting article. This is evaluating the clinical reasoning of student health professionals in placement and clinical setting, or sorry, in placement and simulation settings. So clinical placement and simulation settings. And this is a systematic review. This is out of Australia, so we don't have any authors here to join us today. Brent Thackeray and Judd and this is published in an open access journal. You can go online and get this without hitting that paywall. It's the International Journal of Environmental Research and Public Health. So if you are joining us live, we would like you to use the chat to interact and discuss the topic with other participants, and then use the question and answer to direct your questions directly at the panel, and we can bring those into the conversation as we go. And if you do hear something that you like, please quote, tag, and share. Use hashtag EMS research. And of course, we always love it when you tag at PCRF at UCLA, as well as our sponsor, Limmer Education. Now, first, before we do begin, I do want to remind everybody that there is an upcoming deadline for the abstract deadline that for the Pre-Hospital Care Research Forum abstracts. These are abstracts that for research that will be presented at the International Scientific Symposium at the EMS World Expo Conference in Orlando, Florida in October. So remember, these are education abstracts, they're clinical abstracts, they're system operations, EMS abstracts. And this is the opportunity to present. Some will be selected for oral presentations. Everyone will be presenting a poster. And then there's also the possibility of a cash prize award for the top research. They will be presented with a $500 US dollars cash award and a travel grant up to $2,000. So for presentation of your research at an international conference. So there's still time. There's 1 week. You can do it. Get that in abstract form, and you can always put together the details of additional research as you go before the conference. So we'd love to see your research. Submit those. You can go email pcrf@mednet.ucla.edu, or you can just go to prehospitalcare.org. You'll see where to submit that abstract. So let's see. We've got Alex out there. And we'll try and pull him in too, as well as a panelist, but we're going to be looking at this systematic review. And if you remember, if you've actually joined us, and if you haven't joined us before and you want to listen to some of our previous webinars, you can. We did start and actually we didn't do it, Limmer did it for us. Thank you for Limmer for making our YouTube channel. So we have now a YouTube channel for the Pre-Hospital Care Research Forum webinars that's up and running for the webinars that have been running since January for both the clinical and the education research journal clubs. So you can look those up on the Pre-Hospital Care Research Forum as well. Okay, so in January, if you remember, we talked to Justin Hunter, who was a paramedic researcher, and he joined us and discussed his dissertation research on situational awareness, and he used the situational awareness global assessment tool in paramedic students. So that was one point in time where we have talked about this topic of clinical judgment, clinical reasoning, critical thinking, whatever we want to, situational awareness, all of these terms that are related, interrelated, but distinctly different. Then if you remember last month, Toby Keane, Bill Lord from Australia, we discussed their research on diagnostic intuition, and they looked at a very specific tool as well, or they were developing one and actually proposing one for looking at the specific process of diagnostic intuition when given limited information, such as a dispatch information, and they compared paramedic students to paramedics, experienced paramedics, looking specifically at that process of diagnostic intuition and how they came to a diagnostic conclusion based upon limited information. So in this article, we're kind of building on this theme of how do we get at this? How do we get at clinical reasoning, critical thinking, whatever we want to talk about, call it clinical judgment. And again, they're different terms, but it seems that we keep, kind of using them interrelated. This article underscores the importance of competence in clinical reasoning in a multidisciplinary review. So it's a systematic review, and they use the term, or they use the definition of clinical reasoning from an actual article from 2018. Clinical reasoning, the process of gathering and synthesizing information, generating hypotheses, and formulating a clinical impression, diagnosis, prognosis, treatment, care, or management plan. So that's the process that they were talking about. They were saying that, despite everyone's agreement that this is an important concept, across all of the healthcare professions and healthcare professions education programs, there's a lack of consensus about how it's defined in the related terminology and how it's conceptualized. So again, terms like clinical decision-making, critical thinking, problem solving, clinical judgment, diagnostic reasoning, these are all kind of used without distinct and agreed upon definitions. And then they go on to talk about some of the background that, yes, there's been many systematic reviews and a couple of scoping reviews looking at some of the tools that are used mostly in nursing and in some of the allied health professions, and of course in medicine, that are looking at, examining the research outcomes related to these different tools in the clinical environment. And then in examining simulation programs, and actually that's, Katie, where I wanted to talk to you about, what some of these tools are actually used as, or the presence of the use of a tool is used to evaluate whether an accreditation of a simulation center, for example, or to see if the simulation center is evaluating this kind of process. So one of the gaps, though, that they identify is that there isn't an interdisciplinary, there isn't a look across disciplines. There's very little, if any, look across disciplines. And they wanted to identify tools that would evaluate clinical reasoning and determine the constructs that they're intended to measure. So they did this systematic review, and this is, let's see if I can advance this here. These are the research questions that they have. So what tools have been developed or investigated for evaluating the students' clinical reasoning, as they defined it earlier, as applied in clinical education placements and simulation settings. So specifically in the placement and simulation settings, because some of those earlier tools that they looked at, or the systematic reviews, a lot of them looked at cognitive processes in classrooms and labs. So this was specifically for simulation and clinical and across health professions education programs. Then the second question was, what constructs or aspects of clinical reasoning are those tools designed to assess? So this was the questions that led their research. So they did a systematic review, and the systematic review of the literature involved looking at databases, as we've looked at systematic reviews here, CINAHL through EBSCO, ERIC, Embase, I mean, all the ones that you would think of, Medline, pre-Medline, PsycInfo. They even used ProQuest, which I thought was interesting, ProQuest Nursing and Allied Health. And so those were the databases they used, the wide range of allied health disciplines and medicine. And when you look at the list of their allied health disciplines, they do include paramedicine in this search. This is the inclusion criteria. And at first I thought, well, wait a minute, we reviewed, Justin Hunter's and others, a few others that were paramedics we've talked about, and where were they? But they were after 2018. So these were publications only between 2000 and 2018. So these are peer-reviewed, published between 2000 and 2018, published in English, accessible to the authors. And I don't know what that means. I guess maybe don't know if there are any inaccessible. I'd love to know that. Any health profession, and again, they had a list in here that includes everything from medicine and nursing and paramedicine to occupational therapy, physical therapy, podiatry, social work, psychology, a lot of disciplines. And then they were specifically focusing on pre-licensure student education. So anyone is before registration or licensing student education. They're also looking for clinical reasoning or related concepts. So they used all those terms, all those constructs that we mentioned before, clinical reasoning and clinical judgment and all of those terms, critical thinking. And then the primary outcome had to be, of the study that they were looking at, had to be specific, that they were looking to develop or test an evaluation tool. So that was really what they were looking at, was testing or evaluating or looking at an evaluation tool. So it looks like Bill Toon is joining us too. So we have Bill, Alex, it looks like you're on here too.
I made it, yeah.
Great, thank you. I'm glad we pulled you out of the matrix there. I'm just reviewing the inclusion criteria, and then I'd like to ask you guys about some of these tools that in your kind of areas. So exclusion criteria they used, they had were if they didn't use a test and evaluation tool, if they did it in a setting that wasn't simulation or clinical, or didn't, if it was outside of that setting. So these were the exclusion criteria for the study. And then this is what they came up with. We usually see these, this diagram in a systematic review where you see, how many they came out with when they're big, as they cast their giant net, 7,000 plus records identified, a couple duplicates removed, 57 duplicates removed. And then excluded based upon an abstract screening. That's a lot of abstracts to screen, 7,825 abstracts to have to screen. And then after that, they came down to 196 full text papers. And then you look at why did they exclude them, and predominantly they excluded them because they were outside of the setting. It says they were used in settings such as university classes rather than in clinical and simulation settings, or because they didn't report on the development or evaluation of a tool. So they came down to the 61 papers. And then let's just kind of overview it, and then we'll come back and I want to talk to you. We have the best part about the panel we have today is we've got, Alex, who is in quality improvement, which relates to one of the tools here specifically, and then Katie, who's in simulation, which is part of the question that they're asking is what do we use in simulation, and then Bill has been a longtime educator and can look at the evolution of tools over time in EMS. So with these 61 papers, then they found that the majority are from medicine and nursing, 28 and 25 respectively, and then the others, midwifery, physical therapy, occupational therapy, and pharmacy. Just a couple, smattered in there. Nothing was identified from paramedicine. Like we said, since 2018, there have been several papers, and a couple we've discussed here. So they do say that in their paper, that they've noticed a trend of increasing publications over time, especially since 2015, and that's what they'd said. Distribution of publication years illustrates a trend of increasing publications on this topic over time. So it may be that they just weren't in the time period for us to see. It'd be really interesting to do this kind of screening again. But again, they're not looking just for paramedic, they're looking for a cross-discipline. So that was the first thing, was majority of them in medicine and nursing. That's not surprising. 24.
Well, and Megan, I think it speaks to the fact that we just need to go out and do our own research more, right? Seems to be a common feature of these papers.
Yeah, and this webinar. People are going to be really sick of us saying this, but even small bits of research on, use a tool, evaluate it, send in an abstract, undergo the scrutiny, the discussion that it's a small sample size and everything else, and then contribute to the larger literature, or even better yet, a network. We talk about that a lot too. A network of a few education programs doing the same research on a tool would be really key. So, so the majority of these were in the US, and the majority used 2 tools, and we're gonna look at those. The script concordance test, which focuses on really diagnostic testing, or the ability to formulate a diagnosis, real similar to what we looked at last month. And then the Lasseter was a clinical judgment rubric, which is more of a performance expectations. And that's something I wanted to hear your inputs on. And then in the tables, they have table 2 that has these constructs, and I have table 2 over a couple of pages. But I wanted to talk a little bit, I wanted to get your input on these 2 diagnostic or these 2 tools that were used, and predominantly, and let me forward this so we can look at the tables that they had. So the first table that they had was table 2, which had the construct, meaning, was it clinical decision making they were measuring? Was it clinical judgment? Was it critical thinking? And then the theoretical underpinning, and then the evaluation tool or the measure, and the discipline of the student in parentheses. So you can, just scanning table 2, you can see they came to the conclusion. This is, there's 3 slides for table 2 here. It's a big table. You can see the Lasseter clinical judgment rubric comes up quite a bit in nursing. And this is, so now construct of clinical reasoning and critical thinking. And then also the script concordance comes up. So you see all these different evaluation tools of clinical reasoning, critical thinking, and then there was one that was not specified, and that actually had a few other tests in it. And again, these are the tests to evaluate students in clinical, evaluating the tool, actually, you're evaluating the tool itself, these studies. So let's see, and also at the very bottom of this slide here, you'll see situational awareness is there, and the SAGIT is in there, and that was the one that we talked about with Justin Hunter a few months ago, if you remember, the situational awareness global assessment technique. So we do have some groundwork that we can, build upon. Let's see. So what did you, and let me forward, I'm going to forward from this so that we can look at an example. This is an example that I pulled just from an article. It's not a great example for us, but it just gives you the idea of what the script concordance tool is, or test. They call it the script concordance test. And concordance has to do with, you get a panel of experts and you have them review a case description and the thought process behind an investigative action, then the new information that comes along, and then the thinking, the hypothesis that you come up with and how it's affected. So essentially you'll have, this one just shows the thinking behind giving somebody morphine and also, the diagnostic test that would be ordered. So this is from medicine. This is an example from medicine. But if we were to do one for EMS, you might have a description of a patient, and then if you were thinking of, you might have the initial sort of diagnostic, pulmonary embolism or something, and then you were to find, and then you put a new finding in, this hypothesis would become, and you have this 5-point Likert scale, and it's basically less likely, more likely, or like in this case, it's indicated, strongly indicated, not indicated. And then you have the student, circle these as they go, which is, it's very cognitive, rather than, I don't know exactly how you implement this during a simulation, but Katie, you and I were talking about this. Have you seen this used in simulation or in the clinical setting?
I feel like informally we do it in simulation, where we kind of ask them, like, what are you thinking and what's your, in simulation the term would be like frame. So they're trying to get at their frame of what were you thinking. And so this is especially like when a student does something, you're like, why the heck did they do that? You kind of ask them, what were you thinking? And in simulation, you always want to make sure they didn't mishear something, misinterpret something, or they're in a completely different sim environment than the one you tried to create, So I think that's where it's there informally, but we don't actually, I think, do a great job, especially in EMS simulation, of evaluating and documenting it like this. We do a lot of check sheet. Did you do something or did you not do it? And we don't really do, well, what were they thinking? Because if they were thinking this and that was correct, we don't actually want to change that behavior. But I think a lot of time we do a lot of feedback, not a lot of debriefing or trying to find out what the frame of thought process is, or again, the clinical decision-making, the decision-making processes.
That's right. And that's what I think, in a bit, and if Kim McKenna is able to join us in a bit, I'll bring her in on the reason. One of the reasons why I chose this one as well is because of an article that she's a co-author on. And I have something from that later in this slideshow that might help us at least with the theoretical underpinnings and where to go from here. But one of the things that article does is say, let's agree on this terminology. And what you're saying, which is I think what they're saying in the pre-hospital emergency care article is clinical decision making, clinical reasoning, I think you were using. Reasoning is a process within the decision making process. It's how you're arriving at a decision. Am I saying that right?
Yeah, and I think it's really important that they broke out the diagnosis and management as two parts of that. And it made me think immediately to the registries. I think maybe you could say it was controversial decision to award points for getting the wrong diagnosis on an EKG strip, but the right management. And so to me, it's like, oh, okay, so yeah, if you have the wrong diagnosis, but you still end up with the right treatment, if we never asked a question about what was the diagnosis or what was your provider impression or whatever, but you treated it right, are we actually oh no, what are we actually evaluating? Because if the answer is just, did they give the right medication and the right dose, but for the hella wrong reason, that could be problematic, right?
Bill,
I think. Go ahead, Megan. Sorry.
Because this reminds me of I got the tube. I'm sorry, Alex. This reminds me of, hey, I got the tube. It's okay if peri-intubation hypoxia and I traumatizing the airway, but I got the tube. So yeah, go ahead, Alex.
Well, and one of the biggest things that we struggle with, I think, from a quality improvement and data analytics standpoint is there's no ePCR out there that requires you to document why you did what you did. It only requires you to document what you did. And to KT's point, that if you can't tell the difference between AFib and SVT, but you ultimately land on cardioversion, not saying that that's right, all we've really taught people is rote memorization and not critical decision making. And from that QA/QI and street level education FTO perspective, then all we're really doing is creating people that can read an algorithm, right? And that's why I think something like a concordance test is important and beneficial.
Yeah. And by the way, I'm not advocating for what I was just saying. I was making fun of it. You should not be.
I could tell.
We do want people to understand peri-intubation hypoxia is dangerous, and getting the tube is more than just the end result. It's the process too, and all the things that can go wrong in the process. Seeing the long term. We have some questions coming in, and I can somewhat see those, and I'll be
Craig Evans has been putting a ton of stuff in here. He asked us if we could review all of these tools and tell us our opinion on the efficacy of each. And I'm just going to be blatantly honest, I don't know enough about all of them to be able to do that intelligently.
Let me rewind some of this though, so we can look at some of these too. They came to the conclusion that we see Lasseter clinical judgment rubric quite a bit in the clinical judgment model, and we see clinical decision making, different disciplines too. So let me forward it a little bit, because I think to Craig's point, are there things that we see? I'd love to know with this simulation evaluation tool at the bottom here, it's an adaptation of that. We'll look at Lasseter in just a second, because I think that's important.
Just Lasseter, but they tailored Lasseter to a specific situation.
Yeah, and I think that you see a lot of that, like within discipline, they comment on this. It's like a lot of within discipline, and maybe this is kind of a warning to us too. Are we going to continue to contribute to just within discipline, or are we going to do within discipline and then add, we're going to connect to other disciplines and how we think about the same scenario, right? How do we judge the performance in the same exact scenario compared to nursing and medicine and anybody else who's related in that
Well,
scenario?
I think what's hard about a lot of these scales is we're asking people to take analog information and make it digital too, right? That yes, I should do this task, or yes, I recognize what I'm doing versus why I recognize that, right? And that's what's hard with the significance of some of these exams as well,
Yeah.
or the validity.
And now I'm seeing too, I think you're right. And that it's the end to who is actually the panel of experts and what are they coming up with and how many is going to help you reach saturation. Because ultimately all of these tools require some degree of judgment on the assessor's part. And that's, I'm going to say something that I would think Bill Toon would probably say too. I can see you out there, Bill Toon, but you can unmute at any time. What are we doing to train the educators themselves, and and how do we know that your assessment of this is going to be the same as mine? And that's the one thing that's nice about this script concordance is I looked up an article about how to use the script concordance and how to develop one. So how do we develop one inside of our program, or for a particular condition or judgment? And it starts with a panel, and their panel of experts they recommend is like 10 or 12. So who are the panel of experts that you would choose? Would you choose, preceptors and physicians? Would you choose working paramedics? What would be your panel of experts that you would use to develop? But I really like what Craig said, which is we need more action research in education. I completely agree, action researchers. So
yeah, he also brought up the whole, we should come up with a panel. That's a bunch of people are saying like, one evaluator could be a problem. And even when you use the rubric, right, like your interpretation of the rubric could be a problem. So I think our audience is coming to the same conclusion you are, Megan.
Yeah, and for some reason, I think Bill can't unmute.
He's unmuted.
Oh no, I can unmute now.
Oh, good. And I see on my little panel, mute William Toon, so watch out.
Thank you. Thank you. Do you know, it's as I listen to this discussion, one of the things that comes to mind is that experienced educators probably have that intuition to know when a student is developing judgment, and good judgment, whether it be the situation that they're dealing with or a clinical decision, but yet they may not know the theoretical model that they're making their assessment on. And Katie touched on this when she said, I couldn't talk about all of these tools here, and I'd have to agree with her. I'd have to get each one of them and read the stuff to spend some time with it. But it makes me think that a lot of education, at least in EMS, I can say we can't be doing things totally wrong all these years and not be doing something right. But what I think we've done is some of us have stumbled on to doing something really well, but we don't know the theoretical model we're using. I hope that makes some sense.
Yes, I'm glad you mentioned that too, because that is, see, the theoretical underpinnings, I think, is part of it. And they do mention, when they start talking about like what are the common models that are used, you see Benner's and Bloom's all over the place. So, and Pat Benner's From Novice to Expert is based on the Dreyfus model, right? So that's that whole idea of how a student develops competency as they move through these stages, which brings to mind again something we've talked about, and that's leveling simulations. So these tests need to be also kind of leveled, for lack of a better term, according to where the student is. So the student's going to have a different level of reasoning skills and critical thinking skills, or whatever we want to call it, at different levels of their training. And we'll have different expectations of them at different levels. And what are those? You know, are there sort of generalities without getting so specific that we, you know, we make everything look like we have to be in lockstep? So.
Well, but you bring up a very good point, and I know people have talked about it. I believe you should start simulation or teaching people how to run calls the very first day of class. But yet the expectation would be very different than what I expect them to do when they're in the last month of class.
Yes.
And we broke up our field internship into 4 parts, and the first 3 built to the 4th, which was the summative one, or the capstone field internship. And there was different expectations during each of the things, and it was spelled out and reviewed with the field preceptor, so they knew what they should be evaluating the person to at that point there.
And I'm wondering, so are there any, did you have any problems with developing those 4 segments? Any time where it was like it just doesn't match? You know, the students, or did the preceptors think it you know, followed a good?
Yeah, I was fortunate. I had 2 things I did. Is I had a very small group of field preceptors I worked with, and I paid them, so I got a lot out of them, and that gave me the opportunity. We used to meet about every 6 weeks or every other month during these different phases, so we could normalize again across the students that they had. And the students would typically only have 1 or 2 preceptors during a particular phase of their field internship. You know, we tried not to have them, you know, like every set be a different person that was their quote preceptor. So that helped a great deal.
Yeah. Now let me ask, Alex, can you just describe what your job is?
You know, I think the day that I can fully describe what it is that I do is the day that I got it. I actually, so I oversee an internal education and quality department for ambulance service that covers about 11,000 square miles of Minnesota and Wisconsin. My primary role is data analytics and quality assurance. So I do a lot of research review and does this make sense? But I also oversee our FTO and internal education program.
So you're in, and the reason I asked that is because I wanted to just confirm you're in the practicing licensed field provider education, the continuing and ongoing education.
Right. The postgraduate
Yes.
on your own segment. Yeah. Yep.
And Katie and I are in the initial education area. So do you use simulation in your what we would call in situ simulation, I guess, or even simulation at all in your education, ongoing education?
Yeah, we actually, so our critical care and air care providers are fully simulation-based education. They don't do any lectures in person. Our new 911 providers do a blend, but yeah, we have a full simulation lab with a HAL that was provided to us through a DOT grant. So.
And what tools are used to evaluate and, you know, support the learner?
You know, I wish I could say that I felt like it's well developed. We do more of the critical actions and critical concepts, like the pre-brief, do the scenario, and then leave. But we develop those months in advance and then test it with our educators first to say, would you have understood what the prompt is here?
Yeah, and I think it's probably more important for what I would call a new grad. I mean, that's what in nursing they call them new grads, but you're, you know, newly hired, newly licensed, just newly working, maybe to build on something like this where you would have you could see what their decision-making process is. But even when there's something new or less frequent in the setting, you know, of even an experienced paramedic, just to evaluate what was your reasoning behind this? What was your thinking behind these decisions? Katie, do you stop simulations and ask questions during, you know, to get at clinical reasoning?
Yeah, it really depends on where the learner is at, right? And I think you said this at the beginning of the talk, it's that it has to be tailored to the learner. So I think early on, we know from some of these theoretical frameworks in education that you are an expert in, you probably could tell the exact name of the guy or person. You're not supposed to let novice learners practice the wrong thing. So if you see them doing the wrong thing, you want to stop, pause, figure out what their framework is, adjust if needed, and then let them continue. Because if you just let them run a 20-minute scenario where they make 700 errors, everyone who's watching and participating has just seen it done the wrong way, and that's not helpful to anyone. But when you're getting to the point where they're like should be in capstone internship, hopefully they're not making that many errors. So you can really kind of let them go through without interrupting to see how as they get new clues or the scenario progresses, that changes their framework, right? So kind of what script is doing here, where it's like, if you found out this next, would that change? So you kind of want to wait and let that happen, but only in your learners who are ready for that progression, right?
Yeah,
And I think that's interesting, KT. I'm sorry, Megan. I think that's interesting because the CAME standards for ongoing education of critical care providers say that you should not stop a simulation once they're considered an experienced provider, even if the simulation is unsuccessful. And that's been a really hard thing, both for us from writing our simulations and from our educators' perspective of that patient just died. We didn't recognize the hemorrhage fast enough and control the hemorrhage fast enough. And we should stop and start talking about putting the tourniquet on differently, or wound packing, or spraying TXA in the hole, or whatever the case is. And so I think that's really interesting that once they graduate, the standard is so different, even though there's still, EMS is still this house of people learning to be experts that will learn to be experts until the day they retire.
I just want to jump in there and say I got annoyed when Bill Toon said experienced educators, just because I feel like we have this notion in EMS that the longer you've been breathing around EMS, the better at EMS you are. And maybe it's a fire service culture thing too. And I think we have to be really careful about that, because some of the research would show that what you learned in primary education, you know better than what you're getting through CE. So some of our less experienced providers may have had better quality education, may have been more in tune with the literature, maybe are doing evidence-based practice versus backboarding because they've been backboarding for 25 years and they're super experienced. So I think, yeah, it's the learner, not their certification level, their age, their years of experience. It's the learner where they are.
And I agree with you 100%. But what I'm trying to say is there are individuals out there who have reputations for being good educators, but they may not know why they've been so successful at what they've done. And that can happen with someone who's had a short period of time versus someone who's old. But I agree with you 100%, that you can't, just because I've been this so long doesn't mean I know everything or have done everything.
Yeah, and just because you're a critical care medic doesn't mean I shouldn't interrupt you before you murder my plastic guy.
Yeah. Well, the whole idea of stopping and getting at clinical reasoning, I think some of that is done in like advanced medical life support scenarios where there's a pause point to see, okay, now this is what's been added to it. Now, what are you thinking now? And then a few minutes goes by and something else gets added to it. So it's almost built into some of the things like you've been saying, like all of you have been saying that we have there, but we haven't really teased it apart. Looked at the theoretical underpinnings of this, asked ourselves if it's helpful or harmful, and then, wanting to know if our educators even know why something may or may not be working. So I want to look at the next one.
Kim's with us too. I don't know how much time she has, but I just unmuted.
Hey, Kim.
Good afternoon, everyone.
Hi, Kim. Thanks. I don't even see you on the panel list, so I'm glad you noticed her. How are you, Kim?
I'm doing good. Discussion.
Yeah, this is great. I'm going to forward to something because I know you're on limited time, but this is the Lasseter clinical judgment rubric. So this is the other one that was mentioned, and I pulled an example, and this is really used in nursing. So you're going to look at this, and this it struck me as it looked very similar to some of the things that we use in clinical and field internship in our area, where you have a rating scale and you have these different kind of levels, not everything, but you see the judgment that goes on by the assessor. That's the big issue that they identify with this scale, is the person who is assessing, there is some degree of judgment of being skillful, clear communication, calm, confident manner. There may be some cultural implications here too, about who's the assessor judging this and what kinds of things are they judging. So, but this is extremely common in nursing. So the reason I want to forward a little bit is because one of the reasons I pulled this article was, number one, we've been talking about this idea of clinical decision making now a couple of times just this year in this journal club. And this open access article came out that I want to request every educator out there, or suggest that you pull. It's open access, and it's Kim, who is a co-author. I think, Kim, if you could comment on this. I actually have the framework that you published in here on it. If you could comment on it, that'd be great.
Sure. Well, I think a lot of people know, hopefully everybody on this call knows, that the National Registry is moving away from the psychomotor exam at the, AEMT and paramedic levels, and going to a practice exam that's really going to focus on critical thinking and some of those higher level concepts. And so as part of validity of the exam, they needed to first sort of identify the theoretical framework for clinical judgment. So Mihaela Guijou is, Dr. Mihaela Guijou is the head psychometrician for the National Registry. And she was a lead author on this, and sort of pulled us together to say, okay, what would this concept, this clinical judgment concept, look like in EMS? And so basically defined clinical judgment as having beneath it clinical reasoning, which is that process that you use to come to a decision. And then clinical decision making is the decision you come to, your differential diagnoses and that sort of thing. And all of that sort of lives under that umbrella of clinical judgment. And then if you have the figure, I thought I saw you pull it up. Yeah, there we go. So ultimately came up with this model that said that, one of the things that makes us unique is that we don't see patients in a static space, and the different phases of an EMS call, of a 911 call, require you at each phase of that 911 call, you are sort of thinking about what information do I have so far, and then you're sort of thinking, oh, well, what could this be? And then maybe you're defining your hypothesis. You're like, okay, this is a patient with difficulty breathing and their age and whatnot. And then you're thinking, well, it could be this, it could be asthma, it could be COPD and whatnot. And then as you get more information throughout each of these phases of the call, then you're having to revise that. You're having to make those, use your clinical reasoning throughout the call as each new piece of information comes in to revise your hypotheses and, evaluate the patient, then make maybe a new judgment, and so on and so on and so forth. And that the sort of two overriding things on the top of it would be leadership and communication. And actually, there is an addendum actually to the practice analysis that they performed some peer groups and did some qualitative process to try and actually come up with leadership tasks, communication tasks, and some KSAs that would come under each of those leadership and communication tasks. That was actually just approved by the board last week, so that will probably be coming out really soon. And then that as you go through each of these phases, en route, scene, post-scene, then you are really dependent upon a lot of things like the patient cues. Are they being honest with you, or are they conscious or unconscious, whatever. Environmental cues, and such as what is the environment around you. And Katie challenged me yesterday on an email to say, well, why didn't we talk about protocols and policies? And I was like, dang. Well, I was sort of reflecting on that, and I think that would come under environmental cues, because we don't practice independently as paramedics. And where we practice, our environment really does determine kind of how we approach things. So if you're working in the ER as a paramedic, you're working under a different set of protocols as compared to working in the field, as compared to working on an aircraft. And so perhaps that's where it falls. And then the clinician factors, kind of what's your education background? What are your biases that are going to influence whether you make the right clinical decision or the wrong clinical decision? And so the bottom line is, this was put out with sort of a call to arms for the EMS community to say, this looks like a reasonable model for how we make decisions as advanced providers in the field. And that they were trying to generate a discussion to say, what are we missing? What seems reasonable here? What doesn't seem reasonable? And then you would be able to say, okay, well, what framework for evaluation works within this model? Does that make sense?
Mm-hmm. Yeah, it to me, it looks like it supports the next step in research.
Mm-hmm.
Right.
Yeah.
So
Really interesting that you specifically referenced, like, it would depend on where the paramedic works, like in an ED or something else. But this model is very much like 911 ambulance response model.
So true.
Yeah, so I think that's just interesting. And I know if Sahej was here, he would say, we don't all work on ambulances. So I just thought I'd throw that out since he's not around.
No, that's so funny you say that, because I'm actually teaching with him on the other line, which is why I have to leave in about 10 minutes. But no, you're right. You're right. And so actually my reasoning was wrong. But even let's say we had paramedics within our system who also worked as flight paramedics. So environment does influence protocols depending upon whether as I'm working on my flight paramedic crew today, I'm going to be able to do things and I'm going to think differently than if I'm working on my 911 ambulance. But you're right, it does not, because it includes post-scene, it does not specifically apply to the paramedic who's working in an emergency department. And we know that part of our work issue is the fact that not everybody's working on an ambulance that is licensed as a paramedic.
maybe it's the term post-scene, although I am glad you put post-scene and not transport or something like that, or arrival at hospital, because that would really keep it limited. But at least it's the post-scene part, meaning I guess it still makes the scene sort of the main thing. But even a community paramedic would have these post-encounter situation or reflections and follow-up and things like that. So maybe the post scene could be, considered something different or defined as something different than just leaving a scene of a 911 emergency.
Yeah, I like the word encounter.
Yeah, instead of the encounter and then the post encounter or something like that, because you do want a post encounter. You don't want to just leave and that's it. You do want some follow through and reflection and learning and and that kind of, whether it's a self process of improvement or like where Alex is, whether it's a continuous maintenance improvement, or whether it's actually like community paramedic following up on something later, getting new cues and new hypotheses and new actions for a patient who needs more of that psychosocial intervention. So it's really happy to hear the mention of cultural humility and the recognition that there's points all the way through here to think about context and disparities and potential biases and that kind of thing. So raising that at all step of the way, I think is really important.
Good. Yeah, it's important because it's so linked into medical error, right? Honestly, if you don't really take the full picture of the patient into consideration and your potential biases, I mean, it's really well documented that it's gonna lead to error. It's gonna lead to the wrong decisions, missing differential diagnoses, and the wrong plan for the patient. So,
we're always looking for templates of things, and sometimes there should be some flexibility built in as well. And when we look at some of these previous tools, I think, again, they provide a structure and a framework, but there's always, flexibility built in. And then it leads to what, Craig has been saying a lot in the chat, which is, educators publishing or presenting their different ways of implementing models and inserting things like, how did you evaluate the students' biases, or how did the student self-evaluate their own biases after that simulation or during that simulation? Or, can you insert that into a script concordance test or into a Lasseter tool? It's asking those questions. Where do those things fit into? I think would be,
Right. That's why I really liked Katie's approach to, like, what's your frame? When somebody's making an error during simulation early on and you're asking them, what's your frame? What were you thinking? Because sometimes that really does uncover that their thought, that metacognition is so important for developing, that moving up that novice to expert thing. And so, having them sort of talk aloud, I think, really helps uncover some of those things and helps them to be better at critical thinking, because they realize the errors of their thoughts, and then they can hopefully fix it next time.
Yeah. Any questions, Alex or Bill, about what Kim, so we can let Kim go back to teaching? Thanks for joining us at your break.
Oh, not at all.
Thanks, Kim. I thought that was terrific.
Yes, and please give Sahej a hard time for me, please.
I will definitely do that, and I really encourage everybody to read it and to comment on it, especially if there's something you disagree with or it's controversial or whatever. And I'll certainly pass along the feedback from today to Dr. Guizhou, and she's very interested in hearing people's feedback so that the model can, if it needs to be adjusted, improved. Obviously, if somebody had come up with the perfect answer for defining clinical judgment, clinical reasoning, there wouldn't be so many different models out there.
Yes.
So,
Yes.
Just trying to sort of pin one down that really makes sense for our community.
Yeah, and that actually leads us to one of there were 4 implications of the paper we were just talking about, and one of them, was talking about that you have a lack of consistency in the terminology. So that was the first conclusion that they came to after looking at, or implication, looking at their systematic review. Lack of consistency in terminology, that each tool has limited evidence, and that there's minimal crossover to other allied health disciplines. So that's another thing we have to consider as we're going through. Do we have, the crossover, and that might limit our ability, to do interprofessional education if we're looking at 2 different things. This is something that we talk about a lot. Do we have common outcomes for our students? It's common learning outcomes. Certainly there could be in the area of professionalism and cultural humility, and across the disciplines, a common learning outcome that we could share. And then the evaluation tools that were the most common, the script concordance and the Lasseter, they have 2 contrasting objectives. One tool assesses diagnostic reasoning, and the other to judge performance quality as a reflection of the reasoning process, and raises the issue of the assessors. Who are the assessors, and what kind of training do they have? So. Alex, did you have something? You unmuted.
Nope, I muted myself in my AirPods instead. It's easier to unmute.
Okay, gotcha. So we have a couple of minutes, and I just wanted to go back to this Lasseter clinical judgment rubric. And it's 2 pages, so this is the first one. And again, you can see that there's the first column here about what they're actually interpreting, and then the levels, basically it's a Likert scale, and each one's a rubric, so it tells you within each one what this, how they're evaluated. And I don't know other people's experience with rubrics, but I know we have these forms that are used during field internship, capstone field internship, field experience, and then also in the clinical setting, that have different aspects of care and then different levels, and it's a rubric. But I just don't know how I don't think they're used very well and this is just from my personal program, and these are forms that are used throughout the state of California. I think Katie, you might have experience with this because you've been in California with some of the forms. The California paramedic program directors had developed these forms and that have a rubric, a rating scale, basically. But we commonly see people kind of adopting their own little way of using it, and I don't know if it's used that well. So the assessor is the kind of limiting factor there.
Yeah, so and Craig just said that rubrics are only as good as the author, and that's true. I think the authors are important. I would add application and the training that you give to the evaluators, right? Because I mean, it gives you a starting point, but if we don't all understand like what does assertiveness mean, or what does how are you going to define recognizing? Even those are words that you think they're English and that we should all know, but when you put it into the context of an EMS situation, it can be really different. And I saw Michael Caduceus on the call. He could tell you they had at the EMT program a rubric for putting on a KED that you would have thought was very clear, but he had inconsistent application of that rubric from his evaluators for months. It was something just as, can we evaluate if a student is putting on a KED correctly? Thank God they don't even have to do it anymore, but it took months to get everyone on the same page there. He's chiming in here, and I think that's one like psychomotor skill that we can't do this. When I was at EMS Expo, I asked a group of people in the educator talk, if a student takes consideration for C-spine throughout the entire call and there is no C-spine injury or no indication that there's a C-spine injury, but they never verbalize C-spine, do they still get points? And that room could not come to a consensus. And I bet you amongst all of us, we couldn't. So that's the problem. We got rubrics, but we can't figure out how to implement them.
Yeah. And then this is the second page. Yeah, it's exactly the same thing. And they do mention that in the article, that there's, who's judging calm, confident manner, and, clear communication, because we know that there are differences in ways that people communicate, and not everyone communicates the same. So
we also know there's gender bias in our ways of thinking of if a woman's communicating clearly or if she's not.
Mm-hmm. Yeah, and for sure there are, cultural implications there. So one of the things that they say in the end is, unfortunately, if disciplines do not share a common understanding of the conceptual framework or constructs of clinical reasoning, this may impact on and limit interprofessional learning and collaborative clinical judgments in multidisciplinary teams. And I thought that one sentence spoke volumes, because interprofessional learning and collaborative clinical judgments in multidisciplinary teams. That's something to really, that's sticking with me. Like, we can do this in our micro level in our program, but how is this viewed in terms of judging for the patient, on behalf of the patient, from a nursing level, a physician level, and any of the allied health levels that we interact with, and at all levels. So
even just EMT to paramedic, you know what I mean? Like, we have a very different expectation for EMTs and for what paramedics should be doing clinically speaking. And I don't know if we train them together.
Yeah. Good food for thought. So any final comments? We're approaching the top of the hour. Bill, Alex, any final thoughts on this? Again,
No, it was nice. It would have been, again, it'd be really interesting to have the authors share their thoughts on this, but regardless, it shows an area that I think we need to do more work in. So I look forward to, and it's a shame that EMS can't find any funding for its research.
Mm-hmm.
I would just say that if you're if you're evaluating students in a clinical setting or a simulated clinical setting, not just what they do, but what they're thinking. What they're thinking is just so much more important than what they're doing, for a million different reasons. So just ask them, why did you do what you did? Yeah.
I think especially from like a debriefing perspective, even when you're a 10-year paramedic, it's like, oh, you gave adenosine in this case that we wouldn't have thought of, but it seems like you had a good reason. I mean, that's how you teach the next generation too, is you can't teach clinical gestalt, but you can show people how it works, right?
Yeah, wonderful. Great thought. We're going to leave on that one. I love the word gestalt. So don't forget to join us. Thanks so much again for joining us today. We're going to continue this kind of conversation about how to measure our clinical reasoning, clinical judgment in EMS students and practitioners on the PCRF Education Research Journal Club. So you can join us again next month, Friday, July 22nd, 2022 at 10 a.m. Pacific, noon Central. But don't forget, Dr. Remley Crow and Dr. Tony Fernandez join us every month as well on the second Monday of the month, and they'll be back on July 11th. Thank you so much for joining us. We'll see you next time. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.